Hi, my name is Daniel Lodge and I'm a cardiac surgeon in St. John's, Newfoundland. This talk is about redo cardiac surgery. I'm not going to speak about data and guidelines. I'm going to speak about tips, tricks, and other helpful hints that you can use to do redo cardiac surgery, and it's mostly based upon my own experience over the last number of years in practice. There are many pitfalls of doing redo cardiac surgery. There's a very high risk of misadventure and mortality with reduced sternotomy, and here are some of the many complications that you can cause with reduced sternotomy. You can enter the right ventricle, the right atrium, or the aorta with the sternal saw. You can cut into some of the previous grafts, or you can induce emboli that cause ischemia, or you can cause traction injuries on the right ventricle or the innominate vein that can cause very significant bleeding that's difficult to control. Prior to doing a reduced sternotomy, you may want to consider some of the alternatives. For somebody that needs coronary work, it may be possible to do PCI rather than having to go do and redo CABG. If somebody needs an aortic valve replaced, you may be able to do it with transcatheter aortic valve rather than doing a reduced sternotomy. If somebody needs mitral valve intervention, you may be able to be done with a MitraClip rather than doing a redo cardiac surgery. Or if somebody needs a mitral valve or a tricuspid valve, you may be able to get good access through a right thoracotomy rather than doing a reduced sternotomy. Preoperative imaging is a very important component of doing redo cardiac surgery. One of the most useful tests that you can do is a CT scan prior to going to the operating room. A CT scan will give you a very good idea of proximities of structures to the sternum, particularly the right ventricle, the right atrium, the aorta, and any previous bypass grafts that may be there. A CT scan will also show you the position of any grafts in relationship to the sternum and other structures in the heart, and they'll also demonstrate patency of grafts, and not all grafts are necessarily seen on a coronary angiogram. There may be some grafts that are patent, but the cardiologist is not able to shoot them with dye to show you where they are. You can use the sternal wires on the CT scan to landmark areas of danger. So if you see that the right ventricle is very close to the sternum between the fourth and sixth sternal wires, then when you're cutting through that area on the bone, you have to take extra care to not cut into the right ventricle. Also, it's a good opportunity to assess your peripheral access, particularly if you have calcified femoral arteries or you have a significant amount of peripheral arterial disease either down the iliacs or up in the subclavian arteries. And also you may want to have a look at what your conduit availability is. If somebody's had previous bypass surgery, they may have the vein used out of their one or both legs, and often you don't actually see a big long cut down the leg to give away that the vein has been harvested. It may have been done through some sort of minimally invasive where you don't even see the surgical scar. Once you have planned to do a reduced sternotomy for somebody, there's a few extra steps that you must take prior to doing that skin incision over what you would normally do for a first-time cardiac surgery. Number one, make sure that you have blood in the room and checked. You may need a lot of packed red blood cells very quickly, and it's best to have them all checked and ready to go before you start the incision. You want to have defibrillator pads on the patient and connected to a defibrillator, or at least have the defibrillator very close by along with somebody who knows how to use it. And most importantly, you must have a plan to do redo cardiac surgery. Number one is the cannulation. What arterial access are you going to use? Are you going to use axillary cannulation, femoral cannulation, or are you going to do direct cannulation with the aorta? And also for the venous system, are you going to do a femoral cannulation? Are you going to cannulate the right atrial appendage centrally, or are you going to cannulate the cava directly inside of the chest? You must also make up your mind in advance if you're going to go on pump prior to the sternotomy, or if you're going to wait until the sternotomy is done to go on pump. And also, do you plan to do any cooling, or do you need any antegrade cerebral perfusion? One of the biggest concerns with redo cardiac surgery is the presence of previous bypass grafts. Here in the left-hand pane, you'll see the standard one where you have a left internal mammary artery that's coming straight down onto the LAD of the heart and not coming anywhere close to the sternum or the midline. Here in the second pane, you'll see a left internal mammary artery that comes down, crosses over the midline behind the sternum, crosses back over the midline behind the sternum, and is then put down onto the LAD. Over in the next pane, you see a right internal mammary artery that comes down onto the RCA, and you see a left internal mammary artery that comes down onto the LAD. Neither one of these come behind the sternum where you're going to injure it with the saw, but if you have to do any dissection once you actually get the sternum open, you're going to possibly run into problems, particularly if you're dissecting along the right heart border for access to the atrium. Over on the last pane, you'll actually see where a rima crosses the midline and goes onto the LAD, and this is very dangerous because if you cut into the sternum and then into the rima, you're now going to make your entire LAD territory ischemic, which is a very big problem. Here's the order of operations that I use for redo cardiac surgery. Number one, I make a larger incision than I do on a first-time operation, and I want to expose the sternal notch and the xiphoid so that I can mobilize the sternal notch with cautery, and also I want to come up under the xiphoid, usually with a pair of curved Mayos and my finger, to dissect up as far as I can under the xiphoid to free the right ventricle off the back of the sternum. Up next, you want to saw the anterior and posterior sternal tables. You want to use an oscillating saw rather than the standard reciprocating saw. And normally what I do is I untwist all the wires. I put a Coker or a Kelly on each wire, and then when it's time to actually start cutting with the saw, I get the anesthetist to do a Valsalva maneuver, which pushes the sternum up and away from the heart. It does place some risk of injuring the lungs with the saw, but that's a much lower problem than actually cutting into the heart or some of your bypass grafts. With a Coker and Kelly, then pulling up on those will actually lift the sternum away from the heart, and then I start sawing first of all the anterior sternal table and then the posterior sternal table. So once I've got all the bone cut, I'll usually take a pair of straight Mayo scissors and I'll put them in between the two edges of the sternum and turn the scissors just enough to separate them, and then I should be able to see that I've got the bone divided all the ways along. At that point, then I usually take the wires out and I will use wire twisters my next step, and I'll put a wire twister in between the two edges of the sternum and twist it enough that I'll actually separate the sternal halves enough so that I can use cautery to divide all the scar tissue off the back of the posterior sternal table. And next up, I usually use rakes, which will actually get the assistant to put directly into the marrow and pull on the anterior table and not actually try to get them under the posterior table, because you can actually cause some traction injuries and tearing by putting them all the way there. You can also use a self-retainer in some of the areas, particularly down around the xiphoid. If I'm going to be using central cannulation, the first thing you want to do is expose enough of the aorta so that you can do an arterial cannulation in case you cause any bleeding and need to go on any form of sucker bypass. Following that, I like to expose the right atrium. At the very least, expose the right atrial appendage. If you're planning on using the cava for redo tricuspid surgery, then you're going to need a much more extensive dissection, but if it's just an aortic valve, you just need the right atrial appendage exposed along with the aorta. Once I have adequate cannulation sites, then I like to get enough mobilization of my aorta so I can fully place a cross clamp across the aorta, and that involves separating the aorta from the pulmonary artery and also separating the aorta from the SVC so that you can get your fingers and the cross clamp all the ways down. You can do a lot of the dissection on the posterior portion of the aorta with your fingers rather than doing it sharply. After this, then you start mobilizing all the structures that are needed for the operation. If you need to place an LV vent, you're going to have to go down and expose the right superior pulmonary vein. If you need to do retrograde cardioplegia, then you're going to need to go down onto the right atrium where you can get a retrograde catheter in. If you're doing coronary bypass, you're going to do fairly extensively dissect free the heart border so that you can actually reach around the back of the heart or the other coronary territories if necessary. And very important that you don't touch any of the vein grafts because they all have a soft, cheesy material in them. And if you actually manipulate the grafts, you can very easily knock loose some of that cheesy type material and cause emboli. A frequent debate between surgeons who are doing redo cardiac surgery is, should you find and clamp the internal mammary arteries, or should you let them be when a person has had previous coronary artery bypass surgery? Those people that say yes, you should find them and clamp them will say there's going to be less blood in the field and there's going to be less motion likely because the heart should have a good rest and not be filling up with warm blood that's causing the heart to keep moving. Those people that say no, you shouldn't find the IMAs and clamp them, say that by doing this you're very unlikely to injure the IMAs because if you do injure an IMA on your entry, you're going to have a very significantly different operation because now you may need to control ischemia rather than doing the actual operation that you set out to do. If you don't clamp the IMA, you're probably going to need more cardioplegia to keep the heart arrested. I personally do not go looking for the IMAs. If you're doing aortic valve, typically you'll see a lot of blood running out of the coronary arteries. The best solution to this is to go in and cut out your leaflets, and then all the blood that runs down from the coronaries will actually go down into the LVOT, into your vent, rather than hanging out in the area where it's in the way. Here are some useful tips and tricks for redo cardiac surgery that I find very useful. Number one, I always place a right femoral arterial line for a redo sternotomy. I very rarely cut down on the femoral vessels prior to doing a sternotomy. It's only if there's a case of where I'm particularly concerned about injuring the arterial structures while entering the chest, rather than if the RV is in a close place. So by placing a right femoral arterial line, number one, you have a very good access that you can give to your anesthetists to show a good arterial pressure tracing, but also if you run into troubles during your sternotomy, you can very quickly place a percutaneous arterial cannula in while you can recycle some blood through sucker bypass if necessary. You do have to cut down on that cannula at the end of the case to remove it, but it's a very nice safety net that does not take very much time out of your operation at all. For a redo aortic valve, I'll always consider using a sutureless valve depending on the condition of the root. It's particularly valuable if you're doing something like a redo freestyle bioprosthetic aortic root, which is typically very calcified, and you would have to take out that aortic root. You would have to salvage your buttons off the freestyle without injuring them. Then you would have to do a full root replacement and reanastomose your coronary arteries. The alternative to that is if you have a calcified freestyle, you can just go and cut out the leaflets of the freestyle, you can put a sutureless valve, and you're done. The one caveat with that is a pig has much lower left coronary artery than humans, and if you're putting a sutureless valve into a freestyle graft, you have to be very careful that you don't occlude off the left coronary, which is a much lower position than you would normally be seen in a human being. For mitral valve surgery with a redo, I often like to do a transeptal approach, especially if I'm actually doing tricuspid surgery at the same time. Transeptal gives you a much closer position to the mitral valve than you'll get through the Sondergaard's plane. And if you're doing a tricuspid, then you only have one external suture line that's going to bleed. Here are some useful hints of how to excise a bioprosthetic or a mechanical valve that's already in place. Here in the picture you see a St. Jude trifecta valve that are removed from endocarditis. You can actually see perforations in both of the leaflets there. So to excise a bioprosthetic valve, you cut out the leaflets. Mechanical valve, you obviously can't do that, but once you've got the leaflets out of the way, then you can actually see inside of the valve and see what's underneath as you're cutting. So with any valve, mechanical or bioprosthetic, the next step is to insert a blade between the frame of the valve and the edge of the suturing ring where all the pledgets and sutures are. So what you want to do is you want to usually start out with an 11 blade and go into position where you can actually see where the blade is coming out on the inside of the valve, so you don't stab it in any structure of the heart. Once you've made a small hole, then you can switch over to a 15 blade and you can cut flush right along the metal frame inside the valve, and you can leave all the pledgets and sutures behind, and you can come back for them after. In the case of endocarditis, you usually want to get all that prosthetic material out, but if it's not an endocarditis case, you can leave some of that material behind, and you don't have to be aggressive getting all the pledgets and sutures out, because you may tear some holes in the annulus that will get you into trouble. In this picture, we have a person that I recently saw a couple of months ago who had routine cardiac surgery about 2 years ago. And this here was on their chest, and they showed up in the hospital with this. As you can see in the video, it's somewhat pulsatile. And over on the right on the CT scan, you can actually see the structure that's bulging out of the skin is in continuity with a larger area that contains contrast within the mediastinal space, and it also is working its way out around the wires of the sternum. And you can also see it's in relationship to the aorta, where there's a very small neck that actually connects the aorta, this neck right here, into this space right here. So we can discuss this case along with number one, what's the diagnosis, and two, what would be an operative plan to deal with a case like this in the event you have to do a reduced sternotomy.